Hey guys, this is Christy. I'm going to tell you an overview about my research on hypertrophic cardiomyopathy. And since that's kind of a long name, I'm going to abbreviate it as either HCM or HOCM. Pathophysiology and etiology. So what defines hypertrophic cardiomyopathy? It's unexplained left ventricular hypertrophy without signs of another cardiac or systemic disease. For example, no history of hypertension, valvular disease, or pulmonary disease to explain the development of hypertrophy. The hypertrophy is most commonly within the interventricular septum, which poses a risk of causing left ventricular outflow tract obstruction, hence why it's also called HOCM. But the location of hypertrophy is variant and can be predominantly subaortic or apical, as seen in this picture. The cause of the abnormal hypertrophy in the majority of cases has found to be single gene mutations in the cardiac sarcomere proteins. In the past 20 years of research, more than 1,400 mutations in over 27 genes have been found to be responsible for or associated with HOCM. Other etiologies include abnormal calcium kinetics, excessive sympathetic stimulation, abnormally thickened intramural coronaries, and cardiac structural abnormalities. For further background, HCM was the first cardiac condition discovered to have a genetic cause and is currently the most common inherited cardiac disorder. Most causative genetic mutations are seen to be autosomal dominant. For a study found that 60% of patients who had a genetic mutation had a positive family history. But the disorder has a wide range of phenotypes and severity because research is also showing the genes have variable penetrance and are potentially oligogenic. In other words, the disease may be a result of having multiple mutations that build on each other. The condition affects 1 in 500 individuals in the general population worldwide, and that's regardless of race or gender. And the prevalence appears to be increasing due to the heightened awareness of the condition as well as the availability of diagnostic studies. The heightened awareness, as you're probably familiar, and the publicity of HCM is centered around being the most common cause of sudden death in young athletes. And that's due to the obstruction that occurs during intense activity. For example, a local person, you may remember hearing about one of the LSU baseball players who died in his sleep in 2002 as a result of HOCM. Aside from such cases, which are usually undiagnosed, the average age of diagnosis is between 30 and 60 years old. And of note, a study demonstrated the genetic anticipation phenomenon within a family line with HOCM, which basically showed a predictable pattern of successive generations being diagnosed at a younger age with increased severity of disease. This theory highlights the importance of screening all family members as young as 12 years old because, for example, if grandfather died from sudden cardiac death at 60 and then his son was diagnosed with hypertrophic cardiomyopathy at 35, well, his son, the grandson, may be at risk as young as 18. As far as clinical assessment, patients with hypertrophic cardiomyopathy are often asymptomatic, especially in early disease, and therefore remain undiagnosed. This is partly why sudden cardiac death is the presenting sign in many adolescent patients due to spontaneous VFib or VTAC. But patients who are symptomatic will commonly experience palpitations or pre-syncope or syncopal episode from arrhythmias such as SVT, AFib, or WPW. However, the most common presenting complaint in up to 90% of symptomatic patients is shortness of breath or dyspnea. And these symptoms may occur only upon exertion or extreme activity because that's when the small hypertrophied chamber cannot maintain adequate cardiac output. On physical exam, the only sign classically associated with HCM is a systolic crescendo-decrescendo murmur heard at the left lower sternal border. And this is similar in quality to that of aortic stenosis, but it's going to differ in that the murmur will increase with the Valsalva maneuver due to the decreased preload or the decreased blood flow returning to the heart. And it's going to become more faint with increased preload, such as elevating the legs or squatting. So with this assessment, your differential diagnoses may be an MI, an arrhythmia, valvular disease, or heart failure, especially in an older adult. But with dyspnea on exertion or syncope in a younger patient, an arrhythmia or congenital heart disease may be higher on your differential. So how do you diagnose HOCM? There are no labs findings specific for HOCM, so blood work is only useful for ruling out differentials. A 12-lead EKG is going to be your first step. Although there are no pathognomonic signs on EKG, there are abnormal findings in 75 to 95% of patients with HCM, and these are most commonly left ventricular hypertrophy and nonspecific ST wave abnormalities. So any EKG findings, abnormal findings, are going to be of greater significance in the young, otherwise healthy patients. The definitive diagnosis, however, is made from either a transthoracic echo or cardiovascular magnetic resonance. The echo is going to be the recommended initial image, and MRI usually only follows if echo was inconclusive. Diagnostic criteria for septal hypertrophy is a septum measurement greater than or equal to 15 millimeters, since the left ventricle is 11 millimeters or less in a healthy individual. HCM can also be diagnosed with a ratio of greater than 1.5 of any two wall thickness measurements within the left ventricle, since the location of hypertrophy is not always in the septal wall. If any measurement is greater than 50 millimeters, this is considered massive hypertrophy, and it carries a much worse prognosis. Genetic testing is the other important diagnostic study. It's not yet widely available everywhere, but is used more and more in medical practices. Results may identify a pathogenic mutation known to cause HCM, or sometimes other abnormal DNA variants, or possibly no variants. To further figure out the pattern of inheritance of a patient's specific mutation, all of their first-degree family members would also need to undergo genetic testing. And then clinical screening with an EKG and an echo is particularly important for family members found to have a mutation, and it should be carried out yearly in all members aged 12 to 21, and then at least every 5 years in adults over 21. This screening helps diagnose the young asymptomatic family members early. Treatment. So management is primarily guided by whether the patient has obstructive or non-obstructive morphology. Prior to any therapy, though, these patients should have a comprehensive risk assessment for sudden cardiac death. And if deemed high risk, an implantable cardioverter defibrillator, or ICD, is indicated and can be life-saving from those common fatal arrhythmias. Additionally, for more of prevention, these patients need to be advised to avoid high-intensity activity or exercise. The mainstay of treatment pharmacologically in symptomatic patients is going to be a negative inotrope, like a beta blocker, or a non-DHP calcium channel blocker, like verapamil, because this class allows for improved diastolic filling and the prevention of tachyarrhythmias. Positive inotrope agents like dopamine and epinephrine must be avoided because of obviously the opposite of increased contractility. And then other things to avoid is peripheral vasodilators like nitroglycerin or the DHP class of calcium channel blockers, and diuretics, and that's all due to the way they decrease preload. In patients with severe drug refractory symptoms and left ventricular outflow tract obstruction, surgery is really the next best step. An open heart septal myectomy is favored in the younger HOCM patients with greater septal thicknesses and other cardiovascular or valvular disease, because one surgery can correct the multiple conditions. The other option is an alcohol septal ablation, and it's an alternative but a more favorable option for older patients or those who are not surgical candidates or simply who refuse open heart surgery. So, in conclusion, the goal is to diagnose HOCM in early disease because the sooner it's found, the more closely the patient can be monitored and the more can be done to prevent sudden cardiac death.